Today, I'm very happy to welcome my guest, Dr. Kelli Stajduhar. Kelli is a professor in the School of Nursing and Institute on Aging and Lifelong Health at the University of Victoria, and she's the Canada Research Chair in Palliative Care, Aging, and Community Health. She has worked in oncology, palliative care, and gerontology for 30 plus years as a practicing nurse, educator, and researcher. Her clinical work and research has focused on health service needs for those at the end of life and their families, and on the needs of marginalized and vulnerable populations. And you can learn more at the website equityinpalliativecare.com. So, Kelli, thank you so much for joining me today.
Thanks very much for the invitation, Dr. Wyatt.
I'm really looking forward to our conversation, but I'm just curious to know what drew you to your work in palliative care and the research that they're doing.
hmm Um, I think there's really three things that drew me. And part of it was a personal experience of losing my mom as a young woman. Um, and that coupled with some really early experiences that I had working as a nurse in the hospital. And primarily working with people who did not have a cancer diagnosis, but were people that were dying from liver failure, from kidney failure. And I think in those early days, seeing what I would say now was over intervention
Mhm.
and actually seeing people really suffer and not really get the care that I think that they needed. And that was kind of when I was like 21. I don't know how I knew that that didn't seem right, but it didn't seem right to me as a nurse. And I think what really got me into the space of equity and working with marginalized and vulnerable populations was early work that I did as a nurse in the middle of the AIDS epidemic.
Mm.
And I remember actually caring for somebody with AIDS, I think 3 or 4 months after I um, became a registered nurse, and how kind of stigmatized that whole experience was for the man that I was caring for and his gay partner. And it really kind of affected me deeply and actually drew me to working as a volunteer in the AIDS community for many years. And that was at the time when AIDS would have been considered a diagnosis for which everybody was dying that had AIDS. And the kind of care that I observed and witnessed as a nurse and as a human being, it just really struck me that some people have better access to care and better experiences of care than other people. And so I think that from a very early start of my career, I had a very strong kind of desire to work in spaces with people who were not particularly well treated in our healthcare system at large and in our palliative care system specifically.
Mm. That's it's just so fascinating to me. And I was thinking of all the interviews that I've done over time, how frequently I have heard that story from people that they were inspired by the AIDS epidemic in some way to
Yeah,
enter into this field. And so it's interesting as one of the outcomes of that horrific time is that a lot of people got inspired to try to make things better. And so for what that's worth, it's really good. There's this whole group of people who are out there caring and noticing and trying to make things better. And I remember a similar feeling in early medical school of thinking, this doesn't seem right. It doesn't seem
yeah,
right. It's obvious to me that not everyone receives the same care, the same level of care,
yeah.
and uh, something needs to be restored or rebalanced here in our system.
Yeah, for sure. And I think, I would say over the last, well, more than a decade now, I've really focused my work and research on really trying to think about how we create better and more equitable palliative care services and programs to meet the needs of folks who are often marginalized and stigmatized in our society at large. And maybe in some ways taking a little bit of aim at palliative care, which I think, mainstream palliative care still is quite directed toward kind of white, middle to upper class groups of folks with cancer. That's who is mostly in our palliative care services, at least in Canada. I don't think it's so different in the US or in any other parts of the global north. And so really trying to do some rebalancing because, I mean, even if we look at the history, the old history of hospice and palliative care, even before the kind of introduction of Cicely Saunders and the modern hospice and palliative care movement, those really early, hospices in medieval times were really meant to care for people who were kind of poor and kind of downtrodden in society, if you will. And then I think, if you look at Cicely Saunders' conception of total pain, really not only focusing on that kind of whole person care, but those kind of social dimensions that contribute a lot to our health outcomes, which I think over the last few decades, we've seen those inequities just growing and growing. And with that, seeing people with multiple comorbidities, and we're not seeing them in our palliative care services. We're seeing them in emergency rooms. We're seeing them in tent encampments, sleeping rough on the street. And these are folks that don't make it to our palliative care services all that often for lots of reasons.
And in spite of the fact that those are the people with such comorbidities who would respond the best to palliative care, for whom, I mean, it's really what palliative care is made for, is to
Yeah.
address situations like that. And yet somehow we're not quite bringing it all together.
Yeah, yeah. And I mean, I think there's probably a lot of reasons why things have unfolded like they have, not the least of which, at least in Canada and for sure in the UK, a lot of hospices and palliative care services are funded by donor dollars. And I think that as a society, as kind as we want to think ourselves to be, we still turn a bit of a blind eye to people that seem and look different than us. And so I think, um, people who live in poverty don't have funds to make donations. And I don't want to say that we're palliative care is avoiding those folks because of that, but it certainly will be a factor. And we our services are not designed in ways that actually are all that welcoming for folks that are structurally vulnerable. And so it's not surprising that we don't see a lot of folks in our mainstream palliative care services.
Yeah, that's something another guest told me about hospice services and the here in the US, the low engagement rates for people of color. But she said oftentimes the messaging that comes from hospice, it's not tailored for everyone. It doesn't land well with
No,
everyone, and it's a little bit oblivious to the fact that people have different cultures and different desires for the end of life and think differently about
yeah,
it.
yeah, for sure. And I think the other thing is that a lot of the people that we work with in our clinical services. So I work a lot with people who have housing precarity, who people who use substances, of all sorts, people who have severe persistent mental illness. And I spend a lot of time working with the primary people that support them, which are mostly outreach workers, harm reduction workers, housing workers. And these are settings also that don't have a good understanding of what palliative care even is or how it could possibly benefit the clients that they care about and love. And so we have a situation where we're not super good at our messaging. Even if we were fantastic, I think, we're working with a crowd of people who don't immediately see the benefit. And so there's a lot of work to be done in trying to intersect the two in some meaningful and cooperative manner.
And from your research on inequity of palliative care, I wonder if you have some areas of greatest concerns and what you
Mhm.
wish everyone listening could understand in order to perhaps get them more engaged or involved in meeting some of these problems.
Yeah. I mean, one of the things that I hear a lot from in the palliative care community is we don't see a lot of these folks in our services. And that is taken to mean there must not be an issue. But there is an issue. And these are folks who have very complex, not only medical backgrounds, but very complex social and family dynamics. And so, excuse me, a key message is really that we have to really adapt our services and programs to meet people where they're at. So, in our research, we found a lot of things. Like it's very difficult to prognosticate this group of folks. And I remember going out, and I do work with lots of people who have drug addictions. And I remember going out into the community, and we would take that surprise question. Would you be surprised if somebody died in the next 6 months or a year? And the workers that we work with say we wouldn't be surprised if anybody died. So that's not a good question. The trajectories are much more like chronic illness trajectories. They're kind of up and down. I would say that a lot of the people that we work with have survived a lot. And so they have such a strong survival imperative that being diagnosed with an illness for which we're pretty certain people are going to die doesn't deter people from wanting to survive. So while we might be in kind of a planning mode, these folks are saying, I've survived, 10 drug overdoses, I've survived this liver disease, and I'm going to survive this cancer. So you have that kind of sentiment going on. Most of the people that we work with don't have family caregivers. So, in mainstream palliative care, we're heavily dependent on family members to provide supports. In this context, we don't have those family members. So the people who end up providing most support are paid workers like housing workers and harm reduction workers. Um, but it's not palliative care because it's seen kind of as health care, isn't really seen within the domain of their practice. And I guess the thing that really concerns me is the lack of support for them because they are the folks that are providing the majority of supports with usually the least paid worker on the team, usually the least educated on the team, although super compassionate. And these workers are also working in contexts of inequity and facing these issues every day. So, if you're a harm reduction worker, or an outreach worker, and that day you've reversed 10 drug overdoses, like death is everywhere, but there's no space to kind of handle that. And then workers are kind of seeing deaths and going, these are like really unjust deaths. it's like it's an injustice. Like we see people who, had they had cancer treatment, for example, wouldn't be dying.
Mm,
And so with that comes a huge amount of moral distress and grief on the part of workers, and a lot of moral residue. And the agencies they work for often don't have the kind of counseling supports that we might have who work in the field all the time. And even if they do, not everybody is attuned to the fact that, like, what the realities of their work is. And so my biggest concern, aside from the fact that we see people dying in really terrible situations, and we see people dying in Canada, somebody who's homeless has about half the life expectancy as somebody in the general population. They've got, 4 times the rates of cancer, 5 times the rates of heart disease, 28 times the rates of hepatitis C. Um, but I really am concerned about those workers who surround folks the most, and really trying to provide that group with support, because they really become the primary providers, and in some cases de facto family,
mm.
for folks who are living in rough circumstances.
I'm so glad you brought that up because, as I think about it, those people were attracted to the work they do for their own various reasons. But unlike all of us who got attracted to hospice and palliative care, we understood that it had to do with death and dying. And that was
Yeah,
part of the calling and part of what we
yeah,
came to it for, to work with that. But these workers may have been blindsided by the fact that this is what they end up doing, becoming a caregiver for someone who's dying on the streets,
yeah,
then without maybe having the heart calling for that work
yeah.
that others of us might have, and no training, and
And no
then
support.
no support, no
Yeah.
means of
Yeah. And I
even.
mean, we've been doing so, a lot of our research, like I would say, I'm probably most known in Canada, uh, because I have a very applied focus in my research. So like I didn't kind of, well, none of us, all of us, go into research for a good reason, but you know, I would say that I'm far more interested in developing services and programs for people and strategies than any other academic kind of output that might come from research in a way. And I think, we've been able to do some really cool work in the city that I live in, but also across Canada, in terms of like how do we actually develop programs and services that meet people where they're at, designed in ways that actually get people what they need in a way that is, culturally safe, trauma and violence informed, and taking a harm reduction approach. Because we see where if we wait for people to show up at our door, they're not going to show up. And that means being out and in and with community, and the people that surround folks who are structurally vulnerable, to do those kind of interventions and develop those kind of services and programs together, um, and to not like think that in palliative care we just need to go out and just do some in services and put our palliative care capes on and say, here we are, we're here to help. We actually really need to kind of shift our thinking a little bit to say, we actually need to, we got a group of folks here who are at high risk of dying. And what does that mean? And what can we think about and develop together to support a better end of life experience for people? And that's really the work that we've been trying to move ahead, in Canada for at least the last decade.
Are there some projects you could talk about or some ideas that you have for?
Yeah, I mean, so one of the most promising kind of models that is coming out of Canada right now are, they're kind of like inner city mobile palliative care teams. So we use our research in community and with community to say, okay, if people are only showing up in hospital, if palliative care is not feeling very welcome, if people in the community are not identifying people who are at, high risk of dying and could benefit from a palliative approach to care, we actually need to get into the community and work with and in community. So we ran a little pilot project. So we had a kind of a 2 day a week physician, 4 days a week a nurse, an outreach worker, some social work support. And we said, what if we went into the community? What if our services were, well, literally, we had a nurse on a bike and a physician on a
Mm.
scooter.
Mm.
And we were by this time, very well attached to community organizations that work a lot with these folks. What if we actually went and met people wherever they happen to be, whether that be in a tent, whether that be sleeping rough in a shelter? And what if we worked with the workers to start to think about how could we best identify people? What would a program like this look like? So we have 5 kind of similar teams operating in Canada now in kind of larger cities. And when we did that pilot, I mean, our actual intention was let's test out this model. Let's figure out how it best performs and how things could best be developed. And also track what their healthcare utilization was, because we knew at some point we would have to have some data to do some advocacy around sustainable funding. So we did that. And in the small pilot that we did, we saw a 61% reduction in hospital admissions for
Mm.
that cohort of patients and a 51% reduction in emergency room visits over a year period. And we looked at, their hospital use before and then going onwards. Um, I would say that that was that, and kind of the data that was coming from providers like in emergency departments and in the hospital and in the community was giving us a pretty good indication that a pretty inexpensive team could actually pull a lot of punch for people. And so we have sustainable funding for 3 of those 5 teams in Canada right now. We're working on a larger, like, national evaluation. So there's that kind of mobile model, which seems to work quite well if it is fully engaged with the community. So these are not teams that kind of come in and take over the care. We're really looking to develop the capacity within community and support community and support transitions. So if we have a patient, for example, that's being seen by that team in the community, if they do end up needing to go into a palliative care bed or a hospice, we're following that patient into those settings and really working with the staff in those settings to make those transitions very smooth, because trust is a huge issue in these communities. They don't, just because we're palliative care and nice people, they don't automatically trust us. There's lots of challenges that come up, particularly if somebody is actively using substances. So there's lots of things to consider. So we have the mobile models. We have a few sites in Canada now where we're trying out kind of developing some hospice-like beds in shelters.
Mm.
So this idea of capacitating staff that work in those settings with some support from a nurse or a physician to actually enable people to stay wherever it is that they happen to be, but to have something in the community if needs are greater than what could be managed out in the community. And then we've got a whole other kind of stream of work going on around developing kind of practice guidelines and for like best practices and say, pain management for people who use opioids or illicit drugs of some sort. We've got a whole kind of stream of work going on around like a high percentage of folks that are structurally marginalized in our communities in Canada are Indigenous. So really, really trying to focus on how do we best integrate culturally safe practices into the care of Indigenous people who also face inequities. So we have a whole project going on about, what happens when you don't have a home, what how does dying happen if you're living in a tent, like those kind, and how do communities kind of rally around people to support them, which is really fascinating. What happens when you don't have a family? So we're doing some projects on that. So there's lots of stuff going on, and it's
Wow.
wonderful. And also I think just with groups of people that are just I'm going to say the kinds of people that I first started working with when I got into palliative care, like we're still very much, we believe passionately in the power of community. We believe passionately in, in, trying to not create separate silos of care systems, but really how do we leverage all of the expertise and harness what I think is deep compassion and love in palliative care. And so it's been really great. In my province, I've had tremendous support, for example, from the BC Centre for Palliative Care. We were just at their provincial conference, which the title of the conference was All Together Now. And I just thought that was just the most beautiful
Mm.
title for our theme for a conference, which I think really encapsulates a lot of the equity oriented work that we're doing because it really takes everybody and it really I think um, requires a deep respect for the communities and the people that we serve and allowing them to make their own decisions in their lives whether we agree with them or not. And that's a big lesson I took from my work in HIV and AIDS was that I might not always understand everything. I might not always agree with everything, but everybody is a human being and everybody deserves love and care. And that's the kind of tenor I think we really try to engage people in. That we don't need to feel judgment about what happens for people and so many people are living within very constrained systems and structures that make them much more vulnerable to to inequities. And so we just really try to focus on that and say, okay, where can we step in alongside, kind of be allies in trying to make things just a little bit better for people.
Wow. I have so many thoughts about this. One was I can just imagine that those community workers have to be inspired by the fact just that anyone is noticing or caring or showing up and research is being
Yeah,
done and
yeah,
care teams are showing up and hospice beds are being created, that
yeah,
has to feel like really good support to them, even if they're still doing the same work every day they
yeah,
were before. But now
yeah,
they know that what's happening is visible because I think
yeah,
these patients have been invisible to the hospice and palliative care world and to probably healthcare in general for such a long time.
yeah,
And we really can't go on that way. I've been learning a lot about the compassionate communities approach where as a
yeah,
compassionate community, we cannot allow anyone to be invisible. We have to be
yeah,
seeing everything and looking at
yeah,
everyone in our community and really assessing the gaps in care that exist and taking
yes.
responsibility for them.
Yeah. And I think that has characterized a lot of kind of how I've always, and I think it's because, like I always say, my claim to fame was that I actually never ever worked clinically in a specialized palliative care service. I always worked in palliative care, but I think one of the benefits to me, at least, has been it's allowed me to always question who we're not seeing. And I think that's why an equity lens works really well because it is saying to us, ask yourself the question, who are you not seeing in your palliative care services and why? And I do think it's something that we need to pay attention to. And those workers, I mean, so there's a group that I work with in Victoria called the Community-Based Action Team. And like we've been working together for 8 or 9 years now. These are folks that are workers in the community that I think it was an invitation to come in and start to talk about, issues of death, dying, loss, and grief in their communities, to be a part of, some research that we were doing. But then and to just continue this on. And so I have to say that when I we for the first 2 years we met every 2 weeks for 2 hours for 2 years. Now we meet monthly. Um, and I'm gonna say that when I came to the group to say our research resulted in like we got funding, you guys. I mean, people were crying in the room.
Wow.
And the tears were all about finally somebody's listened to us. And then we took it a step further and we said, okay, well, now we have to hire people for this team. Um, you need to be on the hiring committee. So, like, some of them were a part of hiring the doctor, the nurse, the outreach worker. And then we said, oh, we talked about, okay, well, how do people get referred to this service? We need a completely no barrier referral. So anybody can refer. And I don't know, a couple months ago, we had a referral from a bylaw enforcement officer, like, these people that go around and like ticket you and things like that. And, there are people downtown that see people living rough and all of a sudden a referral comes in from this bylaw enforcement officer saying, I've watched this guy, over the last year, but he seems to be declining and I'm not really sure and I'm not sure who to reach out to. And we'll go, okay, great, we'll go and see him. And, sometimes people are definitely on a palliative trajectory. Sometimes they're not, but our team has kind of taken the stance of, well, whatever this person needs, we're going to figure that out. And then if it's not us, we're going to make sure that they're being taken care of by somebody else. So, it's a very loose, not kind of rigid, like, you have to be a do not resuscitate or you can't be a drug user actively using, or we don't work with any of those kinds of criteria because those are the things that like put barriers up for people.
It's so true.
Um,
I love it's such a creative approach because I'm sure every single case is different. So you have to be
yes,
able to
for
think
sure.
on the fly and you have
Yeah,
to see the problem and come up with ideas or
yeah,
thoughts of what can we do about this? How can we help? And you're
yeah.
right. The more criteria and protocols we have, the more people just keep getting excluded and we're not
Yeah.
really making the impact.
Yeah, so we're very much modeled in an inclusion model, and if they don't quite fit certain things, well, we'll figure out, but we would never like drop somebody out of care. I mean, what happens for some folks is, they'll have illnesses, chronic illnesses, but and they're not doing well because they don't have good housing or they don't have food or they don't have money and they're having to, make money by other means. So we try to figure those things out, like get people on disability. See if we can facilitate some, reasonably stable housing for people, make sure their food's secure. And sometimes people improve and they don't need to be necessarily, I mean, we have a wide definition of palliative care. So, I think a lot of our mainstream programs now are very tied to like, prognostication. I know for us, we have certain services where, well, you can't go into hospice unless you've got, only so many months to live. So we don't really try to, well, we don't have those kind of criteria. So, practically what that means is usually we have we have a group of clients that we're seeing. We have a list that we're keeping an eye on, and we're like checking in with the folks that they're workers that work with them, or we have a list of folks who we have been following and seeing, but have kind of graduated because we've met their social determinants of health, but we try not to kind of lose anybody if we can help it.
And it's interesting. I mean, in palliative and hospice care, we pride ourselves on whole person care,
Yeah,
but true whole person care at the level you're providing, it means where will this person sleep tonight? Where will
yeah,
they get food?
yeah,
You're really looking at
yeah,
literally every aspect of life for that person and how you
yeah,
can support them.
yeah. Well, I always say that in the context of providing palliative care for folks that face inequities, the primary intervention is the social determinants of health. We meet people, some in mainstream palliative care, we've kind of gone to a place of like, if we have to get their pain and symptoms managed, we have to get them up, under control before we can do anything else. In our context, it's like we need to meet, like, people have lived in pain that we see for a long time. That's actually not their primary concern. Their primary concern is, where am I going to sleep tonight? Do I have anything to eat? How can I make money to get drugs if they use substances, or alcohol if they drink? So pain is not the primary intervention. The primary intervention is getting people the things that they need to get some stability in
Mm,
their life. And
yeah.
so, in that sense, the importance of the workers around people, because that's a lot of the work that they do. They are also primary targets for our interventions in palliative care to support them. Um, because they're the folks that, see people every day, know what's going on. Yeah, so I would say that not everybody can work in these spaces. Not everybody's
Mhm.
comfortable. We've had people come into our team or even into our research team who says, this work that you're doing is like really cool and great and everything. And then the moment that they start going out into the community and they see like people are living in some like pretty bad situations, I mean, hopefully people come to their own realization, well, maybe this work isn't for me, and that's fine. I would rather have people realize that than try to keep doing things, because usually that means that we're going to end up harming somebody in some way.
Mm, mm. So true. And I noticed on the website, the Equity and Palliative Care website, and Inequity Informed Advanced Care Planning Tool. And I was really
Yeah,
curious about that and why that's needed.
yeah, sure. Well, maybe I can tell you the story of how that came to be, and it'll make it clear
Yes.
why that's needed. So I think I mentioned earlier, we have this inner city action team, and we have a young woman in our inner city action team who um, uh, have has had a lot of experience being homeless and using drugs. And she actually worked as kind of a peer educator in our community with people who use drugs. And so a really good friend of hers, who also was quite a leader in the community of people who use drugs, he got really sick with a wound infection. And I think he might have had endocarditis as well, and he ended up in hospital. And Paige knew him really well. She had been involved in our palliative care work at that point for probably over a year. And she came to a meeting one day and she was absolutely devastated. And what had happened was that her friend, um, his street name was Meister. He was in hospital and he died. And he had a Detroit Red Wings hockey jersey that he loved and she knew wanted to be gifted to somebody, and it got thrown in the trash.
Mm.
And he also wanted to be buried in his family plot, and he got cremated.
Mm.
And under normal circumstances, like that is such an affront to one's dignity that their wishes were not known, not communicated, not heard. And so she came to the meeting and just was so angry and so hurt and said, I knew what he wanted. I was there all the time. Nobody asked me, nobody talked to me. I
Mm.
know I'm just a peer worker in the drug using community, but like I know a lot about these folks because I work with them every day. And her advocacy efforts were not met with much enthusiasm on behalf of the healthcare system. And so we were in that meeting, and I said to her very gently, I just said, in palliative care, we do this thing called advanced care planning. And we talked about it a little bit and kind of explained it. And she went home, um, and she downloaded the 60-page something advanced care planning guide from our provincial government website. And she came back 2 weeks later with a 6-pager.
Mm.
She said, I want to do advanced care planning in my community. And so we worked on developing and co-developing and workshopping and testing and retesting that advanced care planning document. And so we have some shelter workers that are doing advanced care planning now in the community. And, the hospital social workers were so happy because they're a little bit like detectives in their job. So people come into hospital and they're like, we never have like anybody that knows anybody. We don't know what people want. Sometimes people can't articulate what they want. We're trying to find the next of kin, but even the next of kin might have been estranged for years, and that whole situation honestly reminded me a lot of the AIDS days when, at that time, gay men partners would come into hospital and they'd had a relationship with their partner who was dying for years and years and nobody would listen to them. It
Mhm.
just felt so similar to me. So yeah, so that's why we have advanced care planning tools now. And we really, we're trying to work to, when I said she took the 30 pager and like, or 60 pager and whittled it down to 6 pages, we have to adapt what we have. And, it's the same. I remember early on in our working together with the inner city community, I said, a good nurse educator that I am, oh, we're going to do a palliative care 101 with the workers. And that just fell flat. It was just like people had no idea what I was talking about. It wasn't in language that they could understand. And I was only grateful that there was a few people in the room who knew me fairly well from my AIDS days that said that just did not fly, Kelli. And so I admitted it. I was like, yeah, that didn't fly. Okay, we got to regroup. And we worked with that group to actually just write a little guidebook on kind of palliative care in the context of equity and what that means for inner city work. And co-authored that. And that's something they're like super proud of. They're using with, the folks that they work with in their housing and shelters. And we're just now working toward like turning that into like some kind of facilitator's guide because, even if you think about a concept like grief, you can have a grief counselor come and they would talk about grief. But I think the thing is that unless you're in it, nobody understands how like deeply profound, like they are more like in a disenfranchised grief,
Mhm.
teetering on PTSD from watching people die that shouldn't be dying, so we have to really take those things into account. Just like, a lot of the workers we work with, they don't have access to the medical records of their clients. So how would they even know that they have a disease that is life limiting? So we have to teach them, oh, here's some other things to watch out for. Like, oh, so and so, used to be able to walk 3 blocks to get to the food bank. They can barely walk a block anymore. Like just those kind of adaptations. So yeah, but really engaging them to make sure that we're developing the kinds of things that work for them in their communities. And then not having me go out and do a bad palliative care 101, but actually having, workers in the community doing that education for their peers.
That's such a good point of needing to adapt. And I think we've probably been slow to do that in our
Yeah.
healthcare world, including hospice and palliative care, and to recognize that the way we've done things in the past, what we've created or produced in the past, is simply not going to apply to everyone.
No,
And
exactly.
and that's the same thing as you were saying. We have to get rid of some of the criteria and some of the obstacles that we've created in the past that maybe is part of our gatekeeping that felt necessary, but
Yeah.
it's hurting people and
Yeah.
exclusionary when we apply that to different
Yeah.
populations.
Yeah. So just being much more nimble and open to how we think about these things. And it's kind of like, when we go and do presentations, we think, oh, who's our audience? Well, this is an audience of people that don't have like the same health literacy levels that we have by and large. They may have not attained certain levels of education at all. They might have been brought up in very impoverished kinds of situations. So, I mean, we even think really deeply about, if we're meeting with people in community, where are we meeting? What are we wearing? Like it's just we're very and it's not that we're always authentic in who we are, but it's about, we have to shift our way of being while keeping our authentic selves, but in a way that is going to open up a space for people to feel comfortable and to be able to engage with us. And that's our work to do. That's
Mhm.
not the community's work to do.
Oh, that's so true. And I love the story that you told about how the advanced care planning tool got developed because honestly, people might have thought, oh, this isn't a community that wants to do advanced care planning or could do it. And yet, this man may have had very few possessions, but that
Yeah.
jersey meant something
Yeah.
important to him. Of course it did. How would
Yeah.
we not see that or recognize that?
Yeah.
And
Yeah,
of
I mean, he wore
course,
it and everybody in the community knew because that's basically was his uniform in the community. Um, but and I think it's also about being aware that, some of the things that we've kind of developed in mainstream palliative care, like we did, for example, when we were talking about advanced care planning, we did bring like the serious illness conversation guide, into, for people to look at and the spec tool to look at. And everybody's like, yeah, no, that's not going to work. Nobody will ever do that. So people do actually like, and I think it's a little bit like everywhere. Like if you listen with intention, people, I mean, patients, sometimes we say, oh, patients, their families, they don't want to talk about any of this. Actually, I think people do. And I think they do. They just don't come out and talk about it in maybe the same way that you and I would because we're so used to talking about it. But you'll have a lot of people saying things like, I just have been like feeling really terrible the last month. Oh, that's like an entry point into a conversation. And I think sometimes we miss when we kind of standardize and professionalize everything,
Hmm.
we we miss our capacity to just listen intently for the cues, which I think are much more nuanced and much more subtle. So I'm not saying I have anything against us training people in serious illness conversations, but I think sometimes that gets taken up as a script. I know as a family member who, had somebody die, I knew right away when somebody was using the script with me because I know the script. And
Hmm.
it didn't feel, you know, just didn't feel right.
Didn't feel authentic, and
No, and
they.
and so it's, I think if there's anything else I could say is that like not to remember to bring ourselves into the work that we do, that we have all been drawn to palliative care for particular reasons. I really believe that. And in kind of an healthcare era where everything is standardized, professionalized, like not to forget what we ourselves bring into interaction with others, and that is actually the most powerful tool that we have with the people that we care for is ourselves. Not in a non-boundaried way. Well, I don't even like boundaries as a word, but people want to be cared for by folks that are authentic human beings. That I know for sure in my 30 years of palliative care is that, we will get much more relational practice if we're who we are, if we bring who we are as people into our encounters with patients and families.
That's so true. I remember having that conversation with some brand new nurses in hospice who were really nervous about, do I know enough? Do I have enough tools? Have I learned enough? And saying to them, you already are the greatest tool you could ever use.
Yeah,
Being yourself, just being
yeah,
present, being there with people.
yeah,
And we overlook that sometimes, the power of it. But I
yeah,
think even if each one of us has some intentionality and decides, I don't want people to be invisible to me. I want to
yeah,
see the human beings in my community around me
yeah,
who need help, even if it's painful, even if I feel helpless, even if I don't know what to do. I want to be able to see those people and to
yeah,
find out if there's some way that I could be of help, that I
yeah,
could help meet the needs there.
yeah, yeah, for sure.
And I know that you were a speaker at you mentioned the palliative care conference. If you wanted to talk about that, we were hoping originally we could do this before that conference,
Yeah.
and now it's passed, but it will take place next year again. So would you tell us more about that conference, and maybe people
Yeah.
would be interested in getting it on their radar for next year?
Yeah, I mean, I think the thing I love most about the BC Center for Palliative Care, which is the organization that hosts that conference, is there's a very strong commitment to community development, to the idea of compassionate communities and public health approaches to palliative care, I would say. And that I think that conference is a bringing together of um, the idea of whole person centeredness um, in ways that I think we saw in the early days of hospice and palliative care, but less now. And so, like what I felt, so I did one of the plenary talks, and I talked about equity and I talked about privilege and how, how we we could actually, as healthcare providers, be using our privilege to actually further kind of equity oriented aims. And I want to say that conference was a really good opportunity to kind of fly some of those ideas um, in a very, very safe audience of people who I think hold similar values. So, I mean, I had the best experience, not just because I was talking and because there were so many colleagues of mine that were there, but I think it was a really good example of a conference that actually brought that whole person kind of care centeredness kind of back to the kind of priority of hospice and palliative care, and and I think that's of huge value for us. Plus, the center just does a lot of really, really good work. So that's always showcased as well.
So I'll put a link for the BC Center for Palliative Care and the conference
Yeah.
in the show notes. But would it be open to people from the US who
Oh, I
want?
think so. Yeah, I think
Okay.
they would be very open to that. And it's not an entirely British Columbia centric conference. It's really meant to open up a space to really talk about these ideas of, and I said, the conference theme was all together now. I think that's what they call their conference. And it truly is, we had people there. Well, we did have some people outside of BC there, but also there were really good talks like from the disabilities community, from like the homeless community, from racialized groups, and I think that is something that, I think has gotten lost a little bit. Volunteers, like all of that spiritual care, getting lost in some of those bigger conferences now in palliative care, where we're a little bit more focused on symptoms and other important things, of course. But yeah, I think it just has quite a bit more of a community flavor. And I think for those of us who really sit in those spaces, it's just a wonderful chance to get together, share ideas, learn new things, share our expertise, and just feel a very strong sense of community.
Mm. And my hope is that our conversation here today falls on very welcoming and accepting ears too, and that there are people out there listening who might think, "Oh, I really would like to attend a conference like that." In
Yes.
addition to the other work that I'm doing,
Yeah.
I think
Yeah.
that sounds
Absolutely.
amazing.
Yeah.
Oh, I feel so honored to have had this chance to talk to you, and I'm so impressed with the work you're doing and just the impact that it's having. And can't wait to hear more and read more about your research and where it goes from here.
Well, thank you so much for the invitation, and it's been just fun and delightful to talk.
Yes, yes, I've loved it. There's so many more things I want to ask you, so we could go on, but but we'll end it here for now. But I wish you all the best for the future.
Thanks so much.